Welcome back, everyone, to another episode of Grow Your Path to Wellness. If this is your first time listening, my colleague Amanda and I, we host a new wellness guest every week, and we release our new episodes every Sunday. Per usual, Amanda is taking time away for her maternity leave to care for her new little one. So it is myself hosting our guests for now. She'll be back soon, but like I always say, we aren't rushing her. She's taking her time adjusting to motherhood. So be sure to like, subscribe, follow, so that way you aren't missing out on our latest episodes. Last week, y'all got to see Amanda. She popped back in temporarily as I was out on a much needed vacation. So Amanda hosted a fellow colleague of her own, Jenna Savago. They discussed all about how we can all be more gender affirming in our everyday life. So if you missed that, make sure you go back and tune in. This week we had a little bit of a schedule change, but we all were making it work. So we are kind of airing this week's episode a little bit later, but I am so excited, and I always say I can't speak for Amanda, but we're both very excited to be hosting Dr. Kristen Casey, a fellow TikTok creator and mental health provider, doing all the things. So today I'm hosting her, and we're going to be talking all about anxiety and insomnia and some common questions she gets on the topic, and she's going to be sharing some expertise on this topic that we haven't covered yet. So without further ado, welcome Dr. Kristen Casey. Thank you so much.
Thank you. I am so happy to be here. I'm so happy to finally meet you. Wish Amanda was here too, but we won't hold it against her.
At the end, I'll probably say it at the end of this. We always say, "Hey, you're always welcome to come back if there's another topic."
I would love that. Yeah. So I'm Dr. Kristen Casey. Like Kelsi mentioned, I'm a TikTok creator. I'm also a clinical health psychologist. I specialize in insomnia, anxiety, depression, relationship concerns, and LGBTQIA issues, gender and sexuality concerns. So I do therapy and provide psychodiagnostic assessments in a private practice setting, which I love. One thing that I do a lot of is treatment for anxiety and insomnia, and a lot of times I do it together. So really excited to talk on this topic today.
Yeah, so this might be an overlapping question, but just in general, what got you interested in the topic, primarily of sleep? But
yeah. So it's so interesting because I was never really interested in it until my clinical internship. I had insomnia, I had really bad insomnia growing up, really bad insomnia when I was an EMT on an ambulance because we would do night shift and we would get calls in the middle of the night. So I was frequently waking up to attend to these calls. And it was really tough for me to fall back to sleep. And I was thinking, wow, other than dealing with like vicarious trauma and like doing my job in the middle of the night, what else is inhibiting me from getting good sleep? And a lot of times it was the behavioral things that I was doing, like actually bad sleep habits that I thought were good, but they were actually counterintuitive. So I took a little bit of stock in thinking about sleep in a different way when I was an EMT, but it never really fully hit until I had to do a cognitive behavioral therapy for insomnia course for my training, my clinical internship. And I remember my supervisor telling me, hey, Dr. Casey, Kristen, you have to do this one rotation. And Kelsi, I was dreading it. I was like, I don't want to do the sleep course or the sleep class. Like, this is going to be boring. Like, I don't want to do this. It sounded awful. And if Dr. Gress, if you're hearing this, like, it's not personal, but I just was like, not excited about it. Anyway, when I started to do the class, I actually fell in love. I fell in love with sleep, talking about sleep, researching sleep, everything about sleep and insomnia. And I noticed that a lot of times when people would come to insomnia treatment, they also had a ton of anxiety, which I loved working on anxiety. So it was like my two loves technically coming together. So from there, I really just continued with it. And not many people like to talk about sleep. I'm really passionate about it. But nobody really likes to talk about it. So I'm like, let's talk more about it and like get more information out there because there's a lot of myths. So that's kind of how I got started with it.
And of course you're correct. But sleep is huge, and we spend so much of our life sleeping, and the things that it does for our brain, like we know that like clinically, but it's always been kind of like frustrating to me that it's not something that is talked about more, but it's also, I feel like, minimized because of the society that we live in. It's just like, go, go, go. I have to produce. What's the next thing I have to do? Like, I only need 4 hours of sleep. Like it's fine.
Totally. Yeah. It's so tough, right? Because like you mentioned, even in like it's everywhere, and yet we're not paying that much attention to it. And I think nowadays people are paying more attention to it, which is making me so excited that people are actually, thinking about their sleep, having a different relationship with their sleep, being curious about their sleep routine, because I think sleep is part of our life pie. When our sleep is off, it's likely something else is off, which kind of, as you know, alludes to like some, diagnostic criterion and other mental disorders, right? Of like sleep disturbance. So, if you're just say sleeping too much or sleeping too little, maybe you're stressed, maybe you're anxious, maybe something else is going on. But a lot of times we don't really know what to do about it. We're just like, let me just catch up on sleep the next day, which when I hear that, I cringe. Or let me take melatonin, or let me take over-the-counter meds, which makes sense for acute insomnia, meaning short-term insomnia. But if we have really long-term issues with insomnia, we want to make behavioral changes that are more long-lasting. So yeah, I'm the same boat. I'm happy that people are thinking more about it.
Yeah. Thinking more, and because it's one of those things, like when I feel like the topic of self-care, it's one of those things that I feel like people, when it's like a buzzword or they hear it or something, and then it's like, I know what you're gonna tell me. I know I need to do this. I know I shouldn't be on my phone. I know I should. But it's like, we talk about those things so much because they're so huge, and they have such a big impact. So like, making changes, like you said, that are actually realistic, sustainable. I don't feel like people have access to that part of the information.
You're 100% right. I mean, there's a lot, like you said, there's a lot of buzzwords out there. There's a lot of topics out there, or even blogs, which I think it's great that people are putting out information, but I think it's always helpful to figure out how it applies to you. And of course, talk with your provider and your mental health and your mental health professional about this as well. But sleep treatment looks so different for everybody. Every single person will have like a different course of insomnia treatment. Like I use the traditional protocol, cognitive behavioral therapy for insomnia, but we do make changes for people in terms of like accessibility, if they have another diagnosis, if they have seizures or they have another medical concern. Like we always formulate it to be unique to the client, just like you and I do when we see therapy patients, right? We want it to be a very unique course of treatment. So for some people, 8 hours or 7 hours of sleep might be really beneficial. For someone else, that actually might be not as helpful, because they might wake up feeling incredibly exhausted if they get too much sleep. So for them, 7 hours might be too much. So we really like to take a lot of data before we ever kind of like just throw out, like you said, like, oh, don't be on your phone or stuff like that, because sometimes that could even cause more anxiety when people don't have access to their phones. So
for sure, yeah, very, very client centered, and it's not just like, if you feel like you need help with sleep, there's so many areas that are centered, around you and your needs and your lifestyle. You're not, hopefully, ideally, you're not just getting handed a pamphlet of tips, being like, okay, bye.
Exactly. Yeah.
Okay. Oh, wow. So, and I'm one of those people, like, I know about myself that if I don't get a minimum of 8 hours of sleep, I almost am like, I'm just like, I feel like I need to just start over. Can I just go back to bed and start over before I do anything? Then I say that it's like more people are more sensitive, or just different needs when it comes to amount of sleep.
Totally, totally. And I mean, there's so many myths out there, right? Like you absolutely need 8 hours. Like you said, for you, 8 hours is like the golden standard for your body and like what your needs are, right? And for some people, 8 hours might be unachievable. It might be almost impossible for them to ever actually sleep for 8 hours, right? And then embedded within that, it's like, is it a consolidated 8 hours? Is it broken up? Are you having frequent awakenings? How long do the awakenings last, right? So it really depends on the person. And again, I always like to go back to accessibility and different things, because people might have medical issues that inhibit them from sleeping throughout the night. It might be really difficult to achieve consolidated sleep. So for them, it might be, well, if I could get 4 hours here and then a couple hours later, that's great. I'll take that. So.
And that's, just as effective. Like, we know you can't bank or make up sleep, but it's like, how am I structuring my sleep is also very relevant.
Totally.
Sure. Okay. So I heard you kind of touch on it a little bit, but let's kind of get into your expertise and like what you feel like is the typical treatment for insomnia.
Yeah. So when I see someone for sleep treatment, traditionally I'll do a clinical assessment. What's going on for you? What are your struggles? What are you dealing with right now? What's your life like? Childhood stuff, because I'm a psychologist, I like to go back in time. And then I really like to get a good assessment about sleep. So we give a lot of measures. We give the ISI, which is the Insomnia Severity Index score. We give the sleep need questionnaire, which sometimes looks at a daytime fatigue, so that we could kind of rule out sleep apnea, which is a medical issue. And then we look at, baseline sleep data. So, in the initial appointment, we like to get a lot of we like to look at a lot of factors. We also like to look at other sleep disorders. There's over 70 sleep disorders. So we want to make sure we're treating the right one.
I didn't know that. I mean,
isn't that crazy? Yeah. So I specialize in insomnia. So I really have it focused on there. But if I notice that potentially someone's experiencing like sleep apnea, I might refer to, sleep medicine or primary care and have them, get a polysomnography, which is a fancy word for a sleep study, just to kind of see about oxygen flow and awakenings overnight. Anyway, so we do the assessment, and then the traditional sleep course is 6 to 8 sessions. I usually do them between 30 and 45 minutes if we're following the traditional CBTI protocol. And session by session, we really, really talk about what's your baseline sleep data, meaning the person will fill out a sleep diary. I'm really data driven. I really want to see the numbers because I always tell my clients it would be really, really uncomfortable if I watched you sleep, right? And I calculated the time. So please do that on your own. So calculate your time, talk about your awakenings, talk about when your earliest bedtime is, talk about, how much time you're spending in bed. And then we like to come up with a sleep efficiency score, which is the amount of time that you're sleeping divided by the amount of time in bed. So if you're in bed, just say you're in bed for a couple of hours and then you're sleeping for a couple of hours, we divide those two numbers. And a sleep efficiency score above 85 is what we strive for, although there are complications for some people, like veterans with PTSD traditionally have lower sleep efficiency scores, or women with anxiety, for example. So while we look at the data, we also do a lot of psychoeducation about sleep strategies, and we problem solve barriers. Which is the fun part, which I love doing. So we talk about, what's getting in the way of a good night's sleep for you, and what about your sleep environment? Tell me about your home. I have clients sometimes that will take pictures and show me their bedrooms, which is kind of awkward, right? In therapy, you're like, you don't want to see where I sleep, but I love seeing that because
please.
Yeah, we need the data. We need to know how you're sleeping and what it looks like, because you might have your room set up in a way that makes it difficult for you to wake up in the morning, or the sun is shining right in your face like early in the morning and you want to sleep in a little more. So we assess for all those factors. We look at sleep hygiene. But the three big things that we really, really focus on is sleep drive, which is the body's biological need for sleep. We also look at arousal, which is anxiety. What's keeping you up at night? What sort of thoughts and worries do you have that's preventing you from getting to sleep or maintaining sleep? And then the third is circadian rhythm. So your traditional sleep-wake cycle. Are you a morning owl? No. Morning owl? Yeah, no. Night owl or morning lark? I always mess that up. Yeah.
Okay.
Are you the type that's like a morning person, or are you a night person? Where does your sleep cycle traditionally fall? Because we want to work with that. And then from there, we kind of look at the data. We make changes along the way as well. So we get baseline data and we change. But the thing that people struggle with the most, in my opinion, of course, everybody's going to think about this differently, is that, people struggle with their thoughts about sleep. Thinking about sleep also affects our sleep itself. So that's what we focus on a lot. Yeah.
Those I work with, obviously, I don't specialize in that area, but the power of brain associations.
Oh, yeah.
What are I have a lot of clients who, when they first start, coming and seeing me, they're sleeping fully clothed in their work clothes on their couch.
Yeah. People are doing what they can, right?
For sure, right? And it's like, okay. But my brain starts to just develop these and it doesn't take much for it to develop a very strong association with that object or that bed or the couch or sleep or.
Totally. I mean, you're touching on Pavlov, right? So, the conditioning that happens. I always suggest to my clients only use the bed for sleep and sex, right? Because then your body, like you described it so beautifully, of like, it's going to pair to these things and it's going to expect these activities or these things when you get into bed. So again, I always like to talk about accessibility. Some people work from home, they're in a studio apartment. Sometimes it's hard to say, oh, only use your bed for sleep and sex. They're like, where am I going to do my work? I don't have a couch right now, or I'm in the process of moving. What do I do? So I always say any alterations you can make. If you're sleeping on one side of the bed, then work on the other. If there's a chair in your room, that's even better. Like use your bed as like, your desk if you can, and sit in a chair. Anything that you could do, anything.
clothing, so many. Yeah, I could, like I
Yeah.
said, before we started recording, I was like, I can go so many different directions. But,
Me too, believe me.
I work, in my own work with my own clients. It's like, okay. And I love I want to get this information out there for people, because it's like, just if you're having issues with sleep, that doesn't mean that you have to flip everything on its head and become a morning lark and
Yeah.
up at 5 a.m. and doing these things. It's like, no, like we're gonna
Yeah.
work with our brain, not against it.
Totally. No, I love how you describe that, because I think a lot of times there's this societal pressure, right? Like morning people are more productive. That's not exactly true. You could be extremely productive and be a night person. It's all a matter of working with your own body. I noticed that people who work shifts have the most trouble because they have shifts that change. Sometimes they'll be working nights, sometimes they'll be working days, so it's difficult for them. Or people have a bed partner, right? And that bed partner might be waking up at a certain time that's not consistent with our own circadian rhythm. So we have to really take tune to these things.
For sure. Okay. So how does I guess that correlation with those that struggle with anxiety or with insomnia also having anxiety, like we said, we kind of alluded to, like that's
Yeah.
a pretty common occurrence.
Yeah, I mean, there's a lot of people out there who have insomnia that don't have anxiety as well. So I always like to talk about that first. There are people out there who have insomnia that's not connected to any other mental health issue. That could just be part of your life pie. There might be a predisposing factor, like a genetic component to having insomnia. Like if your parents had insomnia, and then you have like big life events that might cause insomnia, and then there's these factors that maintain these behaviors. So the things that you're doing, and that's usually what we focus on in treatment, because we can't really control the other two, like big life events or how our bodies are formed. But in terms of your question about insomnia and anxiety, I do notice that when we get to the end of treatment, we focus a lot on anti-arousal measures, which is how do we be relaxed in bed? How do we be relaxed to the point where we're actually able to fall asleep? Because people with anxiety normally struggle with the latency to fall asleep, meaning the time it takes them to fall asleep is extremely high. They struggle, they lay in bed, they toss and turn, and they're so concerned about falling asleep that they're looking at the clock, and they're just really, really wrapped up in this. So I notice a lot of times people will be really good with circadian rhythm. They'll wake up at the same time every day. They'll do all the sleep habits. They'll be really, really good about exercise, no naps, less caffeine. They're really good about all that stuff because that seems within their control. But the people who struggle with anxiety normally have an added issue of, like any treatment, of getting your thoughts under control. And what do I do with these thoughts that are really causing distress? The one thing that I notice as well is that there's a tendency to minimize, like you said, like minimize the impact that your thoughts actually have on sleep, because there's a huge correlation. As we know, thoughts affect our sleep, and sleep affects everything else. So we work a lot with people trying to use cognitive behavioral therapy to really look at the thoughts, challenge them, and make them more adaptive and helpful. So if you think about it, we have over 60,000 thoughts a day. It's hard to, capture all of them, right? So what do we do then? Oh, I can't capture my thoughts. Now what? Basically, it's all a matter of noticing. So when you notice that you're worrying about sleep or you're having anxiety and you're laying in bed, what do I do? Of course, if you're anxious in bed, we want you to get out of bed because we want to pair the bed with sleep, right? So you get out of bed, you walk around, you do something low key, but in that you're training your brain. You're training your brain to stay on the path, right? Of like, this thought is not actually helping me fall asleep. This thought actually isn't helpful. I have no solutions for this thought. So one thing that we usually suggest is scheduled worry time. It's actually a concept of, leaning into the worry, allowing space to have worry time that's not close to bed. So people are able to get it out of their system technically. And then when you are laying in bed, you remind yourself, hey, I've worried about this and I've had no viable solutions that I could actually act on. So I have to just actually let this go. And then from there, we kind of, everybody's different. It might also be mindfulness tactics, progressive muscle relaxation, and all of that stuff.
I do so much, and I'm trained. I do a lot of mindfulness-based therapy along in DBT, just different. We all have our approaches and things.
Yeah.
And as you're speaking on that, I was like, I just assumed that mindfulness would be
Totally.
Note, and we know with mindfulness, it's paying attention to the present moment on purpose without judgment.
Totally. Yeah. And think about it. You judge yourself when you can't sleep. You feel a lot of shame if you can't sleep. You're like, why can't I be like everybody else? But most of the time other people struggle too, right?
Yeah.
So that, like you said, I think mindfulness is really important. Something that's not part of the CBTI protocol that I also incorporate is self-compassion. There are other people out there who struggle with this too, and what would you tell them if they're struggling? And now try telling yourself that. People usually cringe when I say that. They're like, oh God, that doesn't feel nice. I don't want to do that, but that's part of it. I think, and to your point about mindfulness, I think mindfulness helps engage our parasympathetic nervous system, which is our relaxation response. And that is exactly what we want to do when we're in bed. Our sympathetic nervous system is like fight or flight, stress, anxiety, cortisol. Oh my goodness. So we want that to kind of quiet down when we're in bed so that we could actually relax, because we can't be stressed and relaxed at the same time. And mindfulness, like you said, really, really helps with all that.
Right. And I feel like there's so many thoughts in my brain. Focus on the first one was, I hear so often, it sounds counterproductive to get out of bed. It's like, if I get out of bed, having it wake me up.
Yeah.
It might be a myth or something to categorize that, but I hear that a lot. And it's like,
totally.
Not exactly.
Yeah. I hear that so often, and I work with people who are so resilient and so smart and so aware and self-aware. They know their bodies, and they're like, I know if I get out of bed, it's going to wake me up. And I'm like, you are probably right. You're going to be awake. You're going to actually probably be more awake. But the whole key is, like you said before, Kelsi, about that paired association. We want that to go away. So a lot of times people have a couple of nights of really poor sleep as they're going through treatment. And I usually really talk about people getting having this experience because they're like, oh gosh, my sleep is getting worse. I'm like, just please stick with it. It's part of the process. It's getting better. But usually, exactly. Just like with DBT treatment and stuff like that, we're really opening some doors here that maybe you haven't accessed in a while. But when people actually get out of bed, I'm really detailed. I'm like, what are you doing in that time? I hope you're not on your phone. I hope you're not on watching TV, right? I hope you're doing your taxes or reading a textbook from grad school or something really, really boring.
So much.
Yeah. And then getting back in bed, because after that, then you're literally, you're training your body, you're training yourself. And that's the whole part. Training comes with a lot of discomfort, and discomfort usually spurs growth, right? So that's the whole point.
And those patterns, they're patterns for a reason, because they didn't form, no pun intended, they didn't form overnight. So they're not going to
right. Exactly.
go in one night. So
yeah,
it's a lot of work. So many moving pieces with it.
So many moving pieces. And the beautiful thing about insomnia treatment is people get better fairly quick. It's a 6-week treatment for a reason. Usually within the first 2 weeks, people are like, wow, I can't believe how much I'm getting better. Or they say, I'm not getting better. And I'm like, let's look at your data. It's likely that maybe you have a couple more minutes of sleep, or, your sleep efficiency score is getting better, or maybe you're spending less time in bed, but the time that you are spending in bed is consolidated sleep. It's not lounging, like bed lounging, which is the devil is like, don't lounge in bed. So yeah, it's, I don't know. I think, like you said about the sleep habits too, sometimes for people, those have been helpful, for survival, right? Staying awake in bed for some people with PTSD, you don't know what's going to happen, right? So you form these habits to keep yourself safe. Yeah, it makes sense.
Sleep.
Totally.
Very vulnerable.
Yeah.
And for people with anxiety, they can feel that, or PTSD. We can, other occurring disorders, but taking those things that, during doing that thorough assessment and probably all throughout that process, I'm assuming you are ruling out co-occurring disorders, medical concerns, and
totally,
an approach where I'm sifting, and what we're left with is that's the route that we're going, where we have
100%.
to first.
Totally. Yeah, you hit the nail on the head. It's like we are constantly, every session I do an assessment, because technically people who are in cognitive behavioral therapy for insomnia treatment, we do the assessments every single session. So we assess your insomnia not only from your sleep diary, but we also use the Insomnia Severity Index score and the sleep need questionnaire. I want to look at your daytime sleepiness. I want to look at what you're struggling with insomnia-wise, in terms of getting to bed and all of that. And the great part, I get really jazzed about this, but we put it in this really nice Excel worksheet that I did not create. One of my colleagues did.
Give it to created, I feel so put together.
Right. If you have a graph, it's like you have your life together. So it graphs all of these numbers, and like people could see it in real time, like how they're getting better. And I think that's the greatest part about it. I mean, in therapy, we assess progress and all of that. It looks a little different here, I think, because you're actually getting to see, like they're seeing like the graphs and like what they have to work on. And then I even notice like my clients, I think they're just such great people because they're like, oh, wow, like, you know, I'm staying in bed too long. And I'm like, this is the part of therapy where we're reading each other's minds and you're becoming your own therapist, which is the best part. So
you see them not only built, like obviously we can't change what we don't acknowledge or what I don't understand or what I don't know. It's like can see that evolution, and they start to pick up on their own patterns, their own behaviors, and facilitating the change without, you know, and I tell everybody, like, that's the purpose of ultimately any kind of therapy is for us to get to a place where we feel like, okay, you're applying these things, these concepts, these tools on your own. I'm always here if you feel like you need to come back, but you need that level of, you know, guidance or assistance now.
Totally. Yeah. I mean, spreading your wings and flying is great. And then like at the end of treatment is we talk a lot about, you know, a sleep plan. Like if something happens in your life that's like super stressful and you don't know like what to do and your sleep is implicated and like you feel like really uneasy about even getting in bed and like what will that look like? Of course, like you said, people could always come back. But I always try to, in terms of this treatment, create a plan that's so solid that they won't ever need me again. You know, I want people to feel so empowered to make these changes on their own and give them all the resources. You know, the National Sleep Foundation is a great one for people. If you are struggling with sleep and you're, you know, not looking for a provider, but you want really reliable information, I usually, you know, push them that way. There's also an app, a CBTI app that you could track all your progress there, which is great. I usually say do it under supervision in therapy, but people use these tools afterwards and, you know, they get better and they stay better and life happens. I mean, people go through divorces, they have kids. I'm sure Amanda's not getting much sleep. You know, there's all these things that are going on, right, that cause sleep issues. So, you know, life will happen, but you have the tools. I mean, there's research out there.
For sure. And a question I get a lot, and this might feel like a backtracking question, but how does somebody like determine if they have like clinical insomnia or sleep issues, or how would somebody make that distinguish, you know, like to say like maybe this is something that it would benefit me to reach out to get maybe possible support or assessment?
Totally. Yeah. I mean, I think of it this way, like there are going to be moments in your life when you are getting less sleep. I think like any issue, if it's really impairing your ability to function, that's when I usually say reach out for help. If you're having a couple of nights of, you know, just say, you got on a plane, you went on vacation, came back, right? Just say there's a time difference, there's jet lag. That's like technically like an acute insomnia issue, meaning like jet lag that lasts like just a couple of days or something like that. You could use over-the-counter medications, of course, talk to your provider. I'm not a prescriber, so just know that. But a lot of times people take like, exogenous melatonin, or they'll take like diphenhydramine, which is in ZQuil and Benadryl and stuff like that to fall asleep. But if you're noticing that it's a constant issue that you're having for a couple of months, I usually say reach out. And if you think about insomnia, it's, difficulty falling asleep, difficulty maintaining sleep, even though there's the opportunity. So that's an important distinction. And then, it occurs at least like 3 times a week. So for people that might mean, oh my God, yes, I absolutely have clinical insomnia. You also might have sleep apnea. You might have, advanced phase sleep syndrome. Like you have to get an assessment. But I think initially, if you're noticing anything that's off with your sleep, try to do some researching, resources and stuff like that, and then reach out if you notice it's impairing your ability to like function at work or school or something.
Mm-hmm. And for folks of it like us in the field, it's very common like to have these issues, and I recommend clients or people that aren't involved already with a treatment team or with any kind of clinical provider outside of a primary care provider. I say like mention it to them because they're generalists and they can connect you with the specialists needed.
Oh, totally. Yeah. And I mean, think about it. I had a client who went to a primary care provider and said, hey, I have sleep issues. And the primary care provider said, oh, let's get a polysomnography, right? which is a sleep study. And usually we only do sleep studies for sleep apnea. As a psychologist, I'll like rule out anything else. And then I'll say, okay, this is out of my scope. It's a medical thing at this point. So they might actually go for the polysomnography first, and their sleep might look fine in terms of oxygen levels. They're getting an adequate amount of breaths per night and all that. And the polysomnographist might say, hey, they're good. They might just see a therapist, and work on sleep changes and all that. So yeah, I mean, like you said, I think either way, whatever provider that you touch on or that you could get connected with will be able to lead you to the right source.
Right. It's like, well, to just be, it's beneficial either way to voice the concern if it's impacting functioning, and, rolling a rule out is a rule out. It's just, okay, what the accessibility as far as what's my first line of getting access to, connection to those types of resources or referrals.
Totally. And to your point too, like if just say you have anxiety and you're talking with a therapist already, you might say like, hey, I can't sleep at night. I'm so anxious, right? So you might work on anxiety treatment and your sleep might actually get better. So you might not even have to reach out about sleep, but it might be you're working on anxiety and your anxiety is great, but you're still kind of struggling with sleep. And at that point you might want to, shift focus or find another provider.
Sure. And we kind of touched on, I want to give appropriate time to like the anxiety piece of things as far as ways you typically treat anxiety related to sleep. I know we kind of touched on like stress, worry time and things, but what falls in with kind of your specialty and how you kind of really target the anxiety piece for people?
Yeah, that's a really, really good question. So basically in my clinical interview, depending on what the patient's coming in for, they might say, I am so anxious, like, oh my gosh, like I can't get my thoughts under control. They also might say, I just can't sleep. So based on whatever they find to be the most severe, after we do like, the generalized anxiety inventory and the ISI and stuff like that, we might look at which is more severe and where we want to start. I like to do one at a time because a lot of times symptoms will remit for either as we go through the course of treatment. I noticed if anxiety is like the primary concern and there's a lot of generalized anxiety around a topic, then we'll focus on that first. And then usually the insomnia part or like the having frequent awakenings at night or like not being able to initiate sleep will kind of get better over time. But usually I will start with whatever's more severe, basically. And client preference. I always like to get a sense for them, like you're the expert on your body and your life. What would be more meaningful for you to start with? And then from there, we kind of talk a little bit more about, a lot of it is cognitive behavioral therapy. For some people, it's acceptance and commitment therapy. For some people, it's DBT, like skills and stuff. So it depends. But a lot of times when it's anxiety relating to sleep itself and initiating sleep, ruling out, is this a trauma-based experience? Is this purely anxiety? Is this a phobia? Like, where is this coming from? Is this health anxiety? If it's generalized anxiety, a lot of times they overlap in terms of the treatment, at least how I view it. Every provider is different. For example, if I'm working with someone with anxiety, but it's a different sort of anxiety, maybe it's like a needle phobia, it might be difficult, in terms of like things overlapping. But if we look at an anxiety hierarchy and, if we talk about like, like talking about the needle and then like, all that stuff, they learn a lot of skills to control their thoughts, and that's going to overlap directly with insomnia treatment of like, you have to be able to control your thoughts and stuff like that. So.
Like the overarching concept. It's like, okay, yep. That's something that we've been working on. And then it can, be, it's like I frame it to my clients of, I don't know, my brain always works as having like comparisons or metaphors or something, but
yeah.
like a toolbox, right?
Yeah.
Like a toolbox. And the goal isn't to have, it's about quality over quantity. So it's like, okay, this method or this approach is working whenever we are, addressing this specific type of anxiety. And we can use those core principles and it's for the sleep piece as well.
100%. I mean, there's so many, and as a clinician, like other modalities, like you could look at all the modalities out there, and there you could always pull some patterns from all of them, right? So it could definitely overlap for sure. I like your idea about the toolbox. I think I might steal that. That's great. You put them all in a toolbox, and then you can open it up when you need it, right? And a lot of that they generalize.
Yeah. Sorry, I didn't mean to.
No, totally cool.
Yeah, it goes. I always, I really promote that idea of like, once you have that toolbox, it's yours.
Right.
It goes everywhere with you. So, it can go with you when you're in bed for sleep. It can go with you if you are at the doctor, and having to get blood work. It's going with you here, and it can be very empowering because they're like, oh, so whenever I have that same dysregulated somatic response, I can do that too. And you're like, yeah,
Yep.
absolutely.
Yeah. It's like,
One is
even
going to
like,
be, but
totally. And like, I like how you touched on mindfulness before, right? Like, I think of diaphragmatic breathing and how helpful it could be for like so many different things, right? Like burnout and anxiety and insomnia and like trying to get to sleep at night. Like, let me do some deep breaths and like, regulate myself in a way that might be different than, a DBT skill of like the tip skill of like pouring water or like ice and stuff.
Yeah. And another thing, and I don't know if you're like, I am fascinated. I when I talk about like the vagus nerve and like
yeah,
of our nervous system. So it's something that came to my mind, like the stimulating and exercise and strengthening vagal tone. And it's one of the biggest things that I touch on, and how can I activate that regulatory part of my nervous system with the vagus nerve.
I love that. I've always wanted to, like, I've learned about it in grad school, and it's something that I don't like normally focus on. And it's actually something that I have on my to-do list to learn more about. So that's great.
It's fascinating. And I mean, it's the biggest nerve in our body, and it directly connects our brain, that regulatory, those regulatory functions, with our gut health, or so many, like our heart rate, our respiratory rate, so many things.
That's amazing. I've worked with people with needle phobia for a long time, and we talked about that quite a bit, about like how it could be connected there. We focus more on like thoughts and like all that other stuff, but like I just think about that all the time, and I have a needle phobia myself. I think that's why I'm intrigued. But I think about like, oh my gosh, like that is so connected to anxiety and could be connected to insomnia too. I mean, if we're really pulling here and thinking about this.
For sure. And I know we set like, and it might be some helpful for people that kind of like I said, like a squirreling off point. We've touched on a couple myths, and are there any other like pretty large or like prominent, not to like put you on the spot for like a talking point I didn't prepare for, but other pretty prominent or common myths about insomnia or anxiety related to sleep?
Yeah, I mean, the biggest one is that people will frequently tell me, like, I wish I could fall asleep like I used to when I was younger. Why can't I get the sleep that I used to when I was younger? And if we think about sleep architecture, infants and newborns are like, they have like 70% of their sleep that's REM sleep. And as we age, it like almost reverses. You get a little more deep sleep. So as you age, your sleep architecture and the stages of sleep that you're in more of the time changes. So that not only that changes, but as we age, there's things that wake us up in the middle of the night, right? We don't need that much sleep. As an adolescent, you might need like 10 hours of sleep. As an older adult, like elder, like over like the age of 70 or 80 years old, I mean, you might not need more than 6 hours of sleep. And you might also have more frequent awakenings. So the amount of sleep that you have actually changes over time, or let me rephrase, the amount of sleep that you might need, that's biologically needed, might change over time. And when we think of, I always talk about sleep architecture, meaning like the stages of sleep and how they look on different ages within the lifespan also change. So when people tell me, oh gosh, in middle school when I was so young, I would just sleep through the whole night, and I think I'm like, I can't even remember my sleep from 2 weeks ago, right? So it's like, I know that there's this tendency to idealize too about like our younger years and potentially how we slept. And sometimes we're good historians with this, and sometimes, we just think about the really good times, right? So, and we're comparing to our current life. So yeah, so that's a big one. Another big one is that, people with anxiety, I had a couple of clients say like, oh, I have anxiety and I'm so concerned about my sleep. That means I should be sleeping more because I am concerned and I'm focusing on it. And we notice even in the CBTI protocol, it'll say the more you focus, sometimes for people with anxiety, it actually gets worse because you're focusing so hard on it. And I'm sure you see this in treatment too, when people focus really, really deeply on something, really good intentions, but it might actually make anxiety worse.
Yes, it can because the amount of my energy and my focus is being put on it, I almost become hyper hyper aware and
Yeah.
sensitive to the thing. It's like if we struggle with health anxiety and
Yes.
I'm Googling and I'm gathering all of the data and the research and it should be making me feel better.
Exactly. And it's,
Yes, but
yeah.
other times, yeah, it can
Other times it's not so helpful. Yeah.
be exacerbating for sure.
Yeah. And then another myth too is, the amount of sleep. So I need 8 hours. I need 8 hours. There are people out there who function great off 8 hours, but I think it's always important to look at that statistic and look at that amount of sleep and really think about what that means. Like, what's the rationale for having a goal that's 8 hours? Is it because you know for sure for you it's good? Do you know for sure you've taken your own data on this? A lot of times when people are looking at like that 8 hour rule, we also notice that they might be discounting other things that might be going on in their life. If you have anxiety, just say you're a woman who has like multiple roles, like you're a working mom, maybe a single working mom, you have 2 jobs or something like that. We really have to think about life circumstances, socioeconomic status, access to resources, all those things might make it difficult for people to fall asleep or maintain sleep. So in an ideal world, if there were no stressors, yeah, 8 hours sounds great, totally achievable. In the 21st century, in 2021 especially, I mean, we have so many different things that we're focused on and so many things that are stressful. So expecting our body to sleep soundly at night with 0 awakenings for 8 hours straight every single night might be, we have to, change our expectations and actually make them more realistic to who we are as a human and the things that we're actually doing. Also, I think you touched on this before, which I thought was such a great addition, was the American culture of like productivity and focus on work and all of that. I mean, if you're working all this time, it's going to be really difficult for you to feel like you have a wind down period. We call it a buffer time at night. So if you're working 12 hours a day, just say you have 2 jobs or something, and you're trying to get to sleep at night and you're forcing yourself, it's like you've had no time to wind down. So it might take you a little longer than the average person who has 1 job potentially.
Right. And a concept that came to my brain when you mentioned that was people maybe like you said not allowing themselves that wind down time, like the importance, I'm using so many words to say the importance of transitioning to sleep, like how unrealistic it is to just say when I lay down I'm expecting myself to fall asleep.
Totally. People don't give themselves enough grace. I mean, and enough compassion, right? Like you worked a full day, like you're on this earth, living is hard. Like there's a lot of things that go on just as a human being. And then you put gender, race, sexuality, all these things on top of it that potentially cause more difficulty for people, right? So I think really affording yourself a little bit more grace and pause when it comes to thinking about and being curious about your sleep and wind down time is important. And the buffer time, I like to talk about like an hour before bed. So if we like reduce electronics, put the lights lower, make the bedroom dark and cool and things like that, put on soft music, candles, things like that, set the mood. Not just when a bed partner is coming over, right? You want to set the mood for yourself, your own self, like when you're about to go to sleep, because you deserve that just as much as anybody else does. That's really important because you're training your body like, okay, now this is the wind down time. So like you mentioned before about that paired association, like when the lights get dim, our body reacts to that because our circadian rhythm, if you think about it, which is our sleep-wake cycle, there's a suprachiasmatic nucleus, and that focuses on our sleep-wake cycle. And the way that it's regulated is by light and consistency. So if you wake up at the same time every day and you expose yourself to light at the right times or not, that will regulate your cycle. It regulates melatonin secretion and a lot of the other biological process things that happen overnight. So I think the biggest takeaway here, if people are able to do it, again, accessibility, is if you could wake up at the same time every single day and have a solid buffer time right before bed, that's great. I also wouldn't focus on a hard bedtime. Everybody's different, of course. You look to your provider for more specific recommendations, but as a blanket statement for sleep hygiene, the wake time is more important than the bedtime. The wake time you could actually control. The bedtime is like you might be anxious, you might be dealing with something, you might get out of work late. But if your alarm goes off, people might say like, Dr. Casey, I don't want to wake up, but you can, you have a choice whether you wake up or not, and whether you take the alarm and get out of bed or not. It's up to you. You might not have motivation. You might hate it. You could hate me for it. I'm cool with it, but it's within, a choice point for you, so those are the biggest takeaways, I think.
And I think that can help. thank you for that piece, because I feel like that can be helpful for people as far as showing themselves grace, whether or not they struggle with anxiety related to sleep, just in general issues with sleep and anxiety. It's just,
oh yeah, I mean,
concept of like, okay, I need to acknowledge what is within my control, what is outside of my control, and actually validate that.
totally. Yeah, people with anxiety, I feel like they have a full-time job on top of people who don't, because you're constantly worried and thinking about things that potentially you can't control. And I think sleep is one of those things that feels so intangible, and the concept feels elusive to people. Like, I don't know how to get control of this. And I think if we're able to be consistent, that's really the biggest key, is like being consistent about thinking about sleep in a good way, helpful way. Of course, if it causes more anxiety, then don't. But your wake time, and then thinking about you as a human on this earth. I mean, it's really difficult to just get through the day for some people. Some people really struggle. And if you're one of those people, I mean, I feel you, and it's really tough. There was a point in my life when it was just a struggle to get up. So I think really trying to focus on, if this is my goal for the day, is waking up at 7 because I have to be work at 8. Let me just try to do that and get out of bed. So
ritualizing things that are within my control.
Totally. 100%. Yeah, I like that.
Well, thank you. I'm just gonna thank you so much. And we ask every guest, another thing to maybe make you feel like you're on the spot, but we ask every guest if there's just any like mantra, something to live by, or last thoughts or tidbit to leave our community with before we wrap up and we sign off.
Oh, that's a good one. I like that.
Doesn't have to be anything huge.
God. Yeah. I have a couple, but I think the one thing that I would say as a takeaway, it's something that I'm trying to strive for myself too, is that the past version of yourself was there for a reason, and it's never too late to make changes to become your ideal self. And you might just have to practice who that person is. You might have to practice waking up at a certain time, or you might have to practice ritualizing your life or something like that. But practice makes progress.
Yes. Well, again, thank you so much. And I know I said that I was going to say this again, but if there, on those other areas that you really specialize in, I know Amanda and I would always be happy to have you back at a later date. So if that is ever something that, I know it takes a lot of time for folks out of their day, and all of us have busy lives, but thank you so much for being here.
I would absolutely. This was so fun. So yes, I will take you up on that offer. This would be great. So.
Okay, guys. So everybody, thank you, Dr. Kristen Casey. Again, we'll put in our show notes. Or is there any other? Are there, words are hard? Are there any other resources that you recommend that we put in the show notes for our listener? I kind of jotted down. I put down your website, drkristencasey.com, your TikTok handle. Mentioned the CBTI app, National Sleep Foundation. Anything else?
Yeah, the sleepfoundation.org, and then the national, gosh, I have to get back to you on this one. It's the National Sleep Alliance. Something like that. Let me get back to you. I don't want to misspeak, because there's two different ones that are very similar, but there's that. I have a book. It's not related to sleep 100%, but we do touch on anxiety in there a lot. So if people are geared more towards like, hey, I have a little bit of sleep issues, but I also struggle with anxiety, it's only a 70-page book. It's like a quick read. It's on Amazon.
What was the title?
It's called Life Lessons to Master Before You Die. It's pretty blunt. But one of the things that people really struggle with is, I want to show up as my ideal self. And how do I do that? And a lot of times people are like, I struggle with sleep and anxiety. Like, what do I do? It's not only geared towards anxiety, but really just making, like you said, really ritualistic habits to create a life that's worth living and a meaningful life.
Authentic too.
Yeah.
All right. Thank you so much. We will have those typed up and put in our show notes. And then if there's anything else, feel free, in the meantime, to email over to us. And if anyone has any questions, like I said, we'll have Dr. Kristen Casey's contact information, or just ways that you can access her content on her platforms, and the show notes as well.
Great. Thank you so much, Kelsi.
No problem. Thank you again. For our listeners, like I said, don't forget to like, subscribe, follow, and please leave us comments, feedback. If there's topics that we haven't touched on and you feel like would be beneficial for you, please, like, reach out to us, contact us, leave comments, and we'll do our best to locate, reliable and effective guests to reach out to and host on that topic if we can. Next week, we will be, which is shocking to me, we'll be at the final episode of our Trauma and Chakra Healing series with Lisa Schaefer. So she's going to be joining me one final time, and we're going to be covering the final chakra being the crown chakra. So we're grateful for all of our guests, but Lisa for giving us so much of her time and providing us with this multi-part series. So make sure you tune in next week for our final installment of that series. Again, everybody, thank you and take care. If I can make my screen bigger to stop recording.